we'll wait a couple minutes while our participants start to join.
I don't know in Boston, Lisa, how the weather was, but Sunday was just exquisite here in DC. I hope our team and lots of our local folks got a chance to get outside.
We had a lot of snow on Friday. It was sunny, but it was cold, and so nothing melted. So it was beautifully sunny.
Sun is good. The return of the sun is a good thing.
But it was cold.
Yeah, that is Boston.
Well, a very good thing. I think all of us are feeling a little bit more optimistic anyway. So we'll continue to share that. And it is a lovely day here again. So we'll take that all in. So everyone, thank you for joining us. We are very excited to kick off just another director series. We've had a bunch of really incredible speakers, and this one will be as well. We're very excited to have Dr. Lisa Iezzoni here with us today. But before we do that, I just want to make sure that everybody knows this is being recorded for internal AHRQ purposes. So we'll be able to share that with AHRQ folks who couldn't join today, so they can go back and watch this conversation as well. I also want to make sure that everybody has their calendars marked. We have a bunch of really great speakers coming up. March 8th from 1 to 2 will Emily Halubowicz will be here. She's the Vice President for Federal Advocacy at the American Heart Association. And Emily will be having a conversation with Boyce Janeski here to discuss ways of interacting with policymakers and strategies for really effectively promoting the impact of like research findings and other activities. So we hope you'll join us for that. The other date to mark your calendar for is March 17th, 12:30 to 1:30 with Dr. Christine Sinsky from the American Medical Association. She'll be having a discussion with Dr. David Myers again about the crisis in clinician well-being and how AHRQ systems research, practice improvement, and data and analytics can help improve the working conditions and reduce burnout. Again, a really important topic that we've all been talking about. And again, and actually there's a new one that you haven't even gotten a calendar invite yet, which we're really excited about, which is on March 25th from 11 to 12. Arsenio Mataka, who is Senior Advisor for Climate and Health Equity to the Assistant Secretary for Health, will be joining for a discussion on the intersection of health equity and climate change, and really about the goals of environmental justice. So anyway, really great speakers. And again, the goal of this is really to challenge our own thinking about on topics that are really critically important to HHS, the Secretary, AHRQ, and others, to really make sure that we're making make sure our work is as effective and innovative as possible. So please make sure you have your questions. Again, this will be a conversation. Please post your questions in the chat. We'll be opening up that towards the end of this discussion after David. And with that, I will turn it over to David to kick us off.
Thanks so much, Jamie, and thanks for the entire team who helps me put these series together. And most importantly, thank you, Lisa, for joining us today. This is a real treat. Most folks at AHRQ wouldn't know this, but I know, Lisa, you do, that when I first started at AHRQ, one of my first creative projects was getting to work with you on one of your books, and it is wonderful to have you back with us now. For the rest of AHRQ, Dr. Lisa Iezzoni is a professor of medicine at the Harvard Medical School, based at the Health Policy Research Center of the Mongan Institute at Mass General. She's conducted numerous studies, both funded by the Agency for Healthcare Research and Quality, the National Institute of Health, CMS, and private foundations. Her early career focused on risk adjustment methods for cost and clinical outcomes and assessing quality of care. So you can understand why her work is so fundamental to many of the things we continue to do today at AHRQ. But since 1998, her research has focused on improving the lived experience and healthcare quality for adults with disability. She's served on numerous national committees and chaired the Medical Diagnostic Equipment Accessibility Standards Advisory Committee for the U.S. Access Board. She's a member of the National Academy of Medicine in recognition of her contributions to the field of health services, research, primary care, and people with disability. She played AHRQ, as I just mentioned, played a small role in supporting her 2005 book, More Than Ramps, A Guide to Improving Healthcare Quality and Access for People with Disabilities. Her newest book, Making Their Days Happen, Paid Personal Assistance Services, Supporting People with Disability Living in Their Homes and Communities, which was published in December 2020 by Temple University Press. I cannot wait to get my hands on a copy. This is about telling the lived experience of the people who make community living possible for so many of our neighbors. So, Lisa, thank you so much for joining us today.
Delighted to be here, David.
Okay, so while I'm looking forward to talking with you about equity and specifically how we can at AHRQ can expand our thinking about health equity to include issues of disability, before we dive into that, I'd love to give you the chance to talk to the team at AHRQ about yourself, about your context, your research career, and how you, and if you'd like, how you shifted from your early work on measurement and quality and risk adjustment into this important work on quality of care and access for people with disabilities.
Thank you, David. So I'm going to be disability culturally competent here. I'm going to describe myself. I'm a white woman with curly gray hair, wearing a gray sweater and a blue and purple scarf. And you already can tell, since I've got the gray hair, that I'm old, but actually being old is better than the alternative, right? But I mentioned that to underscore the fact that I'm a pre-Americans with Disabilities Act person. I'm a pre-ADA person. My experiences are such, my sensibility is such. So let's get into that a little bit. So I was diagnosed with multiple sclerosis during my first semester at Harvard Medical School. I went through the medical school without any delays, but when it came time to apply for an internship or residency, I was told that the medical school, now this was 1983 by this point, had decided in its infinite wisdom that they would not write a letter of recommendation for me to apply for an internship or residency. So that's just a high level summary of how I ended up not being able to become a licensed physician. The Americans with Disabilities Act, which George Herbert Walker Bush said was the proudest moment of his presidency, did not happen until July 26th of 1990. So it was too late for me. But I went right into research, and it was a rich time for health services researchers. I kind of landed in a gold mine, if that's where my life was going to take me. It was right after DRGs were implemented and outcomes research was becoming a thing. And so I was able to just really take a deep dive into that. And I'm not going to spend too much time because I know we want to get to questions, but my success in my career is frankly a classic case of overcompensation. That because of my disability and because of the discrimination I had experienced, I was afraid at every moment that I would be fired because of my disability. And so I worked morning, noon, night. I did what academics are supposed to do. I published lots of papers. I got recognized for that. But over the 12 years of doing that, I never talked publicly about my disability. And during that time, I started using a wheelchair in 1988. But medical school had taught me, we can't cure you, so don't talk about it. And I had kind of, instilled that in my core way of thinking. But then suddenly I realized that that just perpetuated the stigmatization. So when I was promoted to full professor in 1998, I realized it would probably be hard for Harvard Medical School to fire me, although I confess that that fear does still remain. Here I am, even though I'm an old person. But I decided to take a little bit of time to look at what would be meaningful for me to research. And I've been traveling back and forth to Washington, D.C. as a policy researcher. And in airports during those interminable waits, people would come up to me and talk to me about my wheelchair, which was a scooter type wheelchair, and about how they themselves or their parents or their friends or their brother was having trouble walking. And how could they get one for themselves or whoever they felt in their life needed one? And so I did what researchers did. I did a lit search. I found that in the general medical literature, there was almost nothing written about disability. And fortunately, also, I mean, it was a good time because, and here I'm going to be wonky about this, but the National Health Interview Survey Disability Supplement, which was done in 94 and 95, had finally just come out. And so was available for researchers to investigate disability. And NHISD was the single most, the absolute best in terms of disability content of any federal survey. And so I was able to take that. I switched my entire research career to focus on disabilities, and here I am 25 years later, still toiling in the trenches.
Thank you so much for sharing, for both modeling how we can speak about ourselves, but for sharing that part of your career and for speaking out and doing this work. And I'll challenge our colleagues to figure out how we can have the most important data set for you in the future. So one of the things we do in these series, or that I've learned that works, is to help staff figure out what they should be paying attention to offer you the chance right now to tell us what you'd like us to leave with, 2 or 3 take-home top-line messages, and then we'll go into dive into details.
Okay, they're going to be 3.
Okay.
And the first one is that 1/4 of the US population has some form of disability. Disabilities are extremely diverse, but disability actually is a universal human experience. But historically, dating back millennia, it's been terribly stigmatized. The most single common cause of arthritis for adult Americans of disability for adult Americans is arthritis. But mental health conditions are the second most common reason for disability entitlement under Social Security Administration. So I make that point to make the point that disability will not always be visible, but it's there. 1/4 of you or your workforce may have it. So the second point that I want to make is to consider disability in all actions, policies, and procedure. Whenever you're doing something at AHRQ, think, oh, how will that affect people with disabilities? Or what should I think about in relationship to people with disabilities for that action, policy, or procedure? And then the final thing is that people with disabilities do experience disparities. We still are not considered a disparities population by the powers that be, but we do experience disparities. We largely know what to do to solve some of those disparities, but we don't know how to do it. We don't know how to make equity happen. So almost 32 years since the Americans with Disabilities Act, it is still unclear how to make the world accessible for people with disability when it comes to healthcare.
So I'm going to try to do a teach back. What I heard was disability is common and not always visible, and it's diverse. And we need to keep that at the front of our mind, that we need to think about it in our own workplace and in our research funding and how we help healthcare systems. We have to always ask ourselves the question, how does this toolkit, policy, procedure, whatever we're teaching, how did this evidence even collect or not collect information about people with disability? And that there are solutions out there that we, if we learn about, we can help move forward, that there's a will and a focus issue, which I think ties into the first 2 that you told us. Did I get it mostly?
Yeah. And let me just mention the concept here, David, of universal design. And you might have heard of this, that basically when the people out in Berkeley, California, who were the first people to kind of really make a community accessible, they started with a lot of things, but one of the things they started with was curb cuts, also known as curb ramps. So people who are wheelchair users like me could get off the curb without feeling like they were kind of walking off the Grand Canyon. But the point was that once you had curb cuts, it really helped people who went grocery shopping with those little wheeled baskets, people who wheel their suitcases around, and parents with strollers. And so the basic point is that the kind of solutions that will help people with disability are also often the solutions that will help everybody.
So a great reminder, universal design as an overlying principle. Though I would say maybe to push a little, that sometimes we think we know what helps and we implement a solution and it helps one group that it was intended to help, but it creates a new barrier for other groups. And so that I think one of the things we've been talking a lot about in our equity work is it's so important to test these ideas with the communities that'll be impacted to make sure that what we think is the easy solution actually is the right solution. Do you agree?
Yeah.
Or have you?
Yeah, I think so. And, I made notes because you sent me a kind of list of questions. And so, of course, I made notes. And in response to two of your questions, I wrote the following: nothing about us without us. So you have got to get people with disability in the room to help you think about this. And so if I were in a room with a person who is blind, I would say, okay, I don't want you walking out into active traffic down that curb cut. And so I'm willing to have a little bit of bumpy pavement, because if you walk with a white cane, you would have to have the raised kind of little bumps, little dots, the half rounds, they call them, to make sure that you know that you're about to enter traffic. And so you do not walk into active, where cars are passing by. And so we recognize that there are going to be solutions that will work better for me. It's better for me if it's just entirely smooth pavement, but I don't want my friend walking into the street. She uses a white cane. So we make concessions in life, for everybody, to be able to live their lives as they want to or wish. And so we just have to realize that it could be you in that wheelchair, or it could be me who's blind, and so just having that empathy, that solutions will sometimes maybe compromise on a marginal way what might work for other people, but it works for everybody to some extent.
So I'd love to give you a chance to talk about your recent research, which has making some nice waves, good waves in the study. You and your colleagues have been publishing, I think, very thought-provoking findings from a survey you did on healthcare professionals around topics of caring for people with disability. And I'd love it if you'd reflect on what this work means to you and what you think it should mean to healthcare systems, delivery systems.
Okay, David, in your questions to me, you said we did a survey of healthcare professionals. We did not do a survey of healthcare professionals. We did a survey of doctors. And so the basic point is that what we found out was about doctors, and it was not pretty. So we were very privileged to get funding from NICHD, National Institute for Child Health and Human Development, to conduct the first ever national survey of practicing physicians. And we focused on 7 specialties, and we focused on physicians practicing in outpatient settings. And I can answer questions during the chat period if anybody wants to hear more details. But our first paper came out in February 2021 in Health Affairs. And by the way, we couldn't get any medical journals interested in it. So I love Health Affairs. Health Affairs, I'm not dissing you by what I'm about to say, but we felt like we needed to talk to doctors about what we found, but medical journals didn't want to hear. And this is something that I hear repeatedly from people who do research on disability, that medical journals just don't want to publish it. But that was an aside, something that I'm hoping that AHRQ can maybe help medical journals figure out, that, we want to hear some of the research about disability. So our first paper came out in February of 2021. And the top line findings, so there were 3 top line findings. The first one was that 82% of physicians think that the quality of life for people with significant disability is worse than the quality of life that other people have. 82%. Okay. The second top line finding, for me, this was also really worrisome, because doctors are not shrinking violets. They're willing and happy to tell you when they're really, really good. Only 41% of physicians said that they felt strongly able to provide the same quality of care to people with disability as they provide to other patients. So that's nearly 60% of physicians who do not feel strong and confident that they can provide the same quality of care to people with disabilities as they do to their other patients. And then the final top line finding was only 56% of physicians strongly welcome people with disability into their practices. So those findings were the first ones that kind of caused a bit of a firestorm. But in January, we published the second paper also in Health Affairs. And let me just say that I got to a certain point with a medical journal where I thought it was going to be able to be published there, but they wanted us to cut it to 1,200 words, which would have made it like 2 or 3 paragraphs long. And so I pulled it from that high impact medical journal because I thought that that was just unbelievably disrespectful to these findings, because these findings were, again, some kind of scary findings. So 36% of physicians reported knowing little or nothing about the Americans with Disabilities Act. And we administered this survey in the fall of 2019 and spring of 2020. So this is almost 30 years following the passage of the ADA. 71% of physicians gave incorrect answers about who determines reasonable accommodations for patients when they come to the office to see the physician. 20% of physicians gave incorrect answers about who pays for those accommodations. And 68% of physicians said that they had some risk of an ADA lawsuit because of concerns about their ability to accommodate patients. Again, I think that should have gone in a high impact medical journal, but we're happy and grateful and thankful to have it in Health Affairs. But I think that it's really astonishing that there's been just so much resistance to hearing about this in the medical community. We were able to get a smaller paper, a brief report into JAMA Ophthalmology recently, which had some kind of really just astonishing findings. So here I'm going to go in another direction. So 37% of physicians never provide printed materials in large font to their patients who have vision limitations. 37% never provide large font printed material, and almost half rarely or never describe the clinic office when they escort a blind patient into that space. Nearly half. And so those are both kind of like really low tech kind of solutions, like large print font, or, you know, just simply describing the office. So just pretty astonishing findings. I'll stop there. There's more, but I'll stop there.
It's actually sort of breathtaking and almost really a moral issue that 56, if I heard it right, 56% of healthcare professionals, people in the healing professions,
doctors,
the doctors.
You're a doctor. I know it might be hard for you to say this, David.
Well, I don't like it's normally that I don't like calling everybody doctors. This is a case where I should be calling
physicians. Physicians. Right,
no,
yeah.
but that it different issues. But yes, that physicians, 56% of physicians would say they actively don't want people with disabilities.
No, only 56% strongly welcome them. So
okay, only
44% do
Sorry.
not strongly welcome that. So that's an equally just appalling
Okay, good.
number.
Yes, that was
all
appalling
of
enough.
these numbers are pretty appalling, every single one of them.
Well, but they may need different solutions,
You're right. Yeah.
So some of this is just what are we doing as a society to teach our, in this case, physicians, but I'm going to assume that this is broader, about the role that we create in the partnership of the healthcare system with people with disability. Two, that we make our system unwelcome or inaccessible to the people we're trying to care for. And our education system seems also a little off.
But David, you forgot the first thing that I said. And that is that 82% of doctors think people like me have worse quality of life than you do.
Well,
So if you start with disrespecting the person, you don't give them the dignity and respect to think that their life might be just like anybody else's life. Pluses, minuses, happy times, sad times. It's just like anybody else. And there are going to be exceptions. And I recognize that disabling conditions can be incredibly painful and can definitely decrease the quality of life. And so I do not want to imply that that is not the case. But there have been studies, and the vast majority of us, and by the way, I've had multiple sclerosis now for 45 years, and I've used a wheelchair for 34 years. And if I viewed my life as a tragedy for that entire time, I never would have, I'd still be kind of under the covers in bed, And so the fact that physicians start out by having little respect for the lives of people with disability is all that I need to be told about why maybe they're not bothering to learn about the ADA, not learning about how to accommodate patients. By the way, the correct answer that 71% of physicians did not have to how you have to, think about making reasonable accommodations for people with disability differs for Title II and Title III practices. Title II practices are practices that are owned or operated by government, like public clinics. Title III practices are practices like my hospital's practice, that is a private nonprofit organization or a private, for-profit organization. They're slightly different, but in both Title II and Title III facilities, patients are supposed to be consulted. You're supposed to say, so Lisa, what would be the best way for us to accommodate you? And here I'm just going to reveal something, and sometimes I'm public about this. And so I'll just reveal something that I had to have an abdominal ultrasound recently. I stayed in my rehab power wheelchair. I did not transfer onto a table because with that rehab power wheelchair, I can go back and become supine. And so the technician, whose name was Jennifer, said, how can we make this easiest? And I said, I'll just stay in my wheelchair. She was great. And so that meant that she didn't have the possibility of injuring herself by transferring me. And I didn't have to get out of my wheelchair to be transferred. And so, there are ways of doing this. If you just have people who will talk, and think things through. But physicians, 71% of physicians do not know that.
So many places I'd like to go, and I'm guessing our team is starting to have questions too. But speaking to us at AHRQ, I think that we fund healthcare research, health systems research, health services research, and then we also are committed to helping healthcare systems and healthcare professionals, doctors, nurses, technicians, improve the quality, safety, and equity of healthcare. How have you, who I know if, and since I'm so glad you read the questions and are using the interview, what can you say back to us about how we, as an agency, where would you prioritize where we could go to help move this field forward?
It was a really provocative question when I got that in your list of questions, David, because here we are, nearly 32 years after the ADA. And let me make the point that I didn't give you the answers about accessible medical diagnostic equipment. Only 22% of physicians usually or always have wheelchair accessible weight scales for patients with disabilities, mobility disabilities, and only 40% usually or always use a height adjustable exam table. In January of 2017, the National Standards Board, Access Board, and the FDA came out with standards for medical diagnostic equipment. But in December of 2017, the Trump administration rescinded Department of Justice rulemaking to talk about how widely available that equipment should be. So we know what should be done. We know how to make equipment accessible, but it is simply not available in facilities. And so one of the things that I think you could be doing is going out there and learning, what are the barriers? What are the barriers to, here's a solution. Why haven't you implemented these solutions? What are the barriers to doing this? And I think that the barriers are going to be manyfold and are going to be misinformation. You know, a lot of providers erroneously think that equipment is going to cost them a lot of money. Some equipment will cost them more than non-accessible equipment, but think about the fact that you will probably save money on injuries to your staff, you know, because injuries to practice staff are often caused by transferring patients. And so you have to bring new staff in and retrain or train new staff in when your former staff who are now injured go out on medical leave. And so just learning about what the barriers are. When I did interviews with individual physicians in preparation of the survey. And so I just heard these things like, okay, so why don't you print out large font print? Well, because our electronic health record it doesn't kind of link up with our printer to allow us to print up large font print. How can we fix this? Is that really true? Is it really true that electronic health records do not allow you to print out in large font? You know, and how can we get electronic health records to make, in a very accessible way, information, and in this case, I mean accessible to the practice staff who may be people with disabilities, but accessible when somebody's coming in for a visit? How can we come up with a list of accommodations that patients might need or have used in the past? So for example, the National Health Service in the UK calls accommodations adjustments. But they have, through their National Health Service information system that covers the entire country, they've come up with categories of adjustments. They've come up with ways for the practice staff to record these adjustments. They did pilot studies of how well this works. So think about that, pilot studies. AHRQ can do pilot studies on how to do this, you know, and they did it with people with intellectual disability. And so they came up with a mechanism for a health system to have information readily at the fingertips of practice staff when patients come in with disabilities about what accommodations they might need. So there are just some examples, but I wanted to say also, when you think about your own staff at AHRQ, you might want to think about just getting together an advisory committee of people at AHRQ who are willing to self-identify as having a disability and who are willing to sit down and think about, what can we do here to make our lives better? And thinking in terms of universal design and in terms of the fact that a lot of you, if you're not currently disabled, will have a disability at some point in your life. And so how can we make things better? And so basically have, you know, just like there are diversity and equity inclusion committees now forming, and most of them are focused around race and ethnicity, which is absolutely essential. But we also, and some of them are now focused around LGBTQ. But I was the one who had to suggest to our Department of Medicine department chair when she created those diversity committees that, whoa, maybe we should include one about disability.
Absolutely. We're there with you. I have lots more, and I'm just going to jump because I want the team to be able to join us to what I told you would be my 3 final questions. Is there anything you wish we had already spoken about that we haven't, that you can share? Who do you think is doing great work out there that AHRQ should be listening to and learning from? And do you have any additional resources where if people who were inspired listening to our conversation today, that you'd say to them, this is a good place to go and learn?
Okay, so I did make notes and I'm just scrolling down. So I have the exact title of where I think you should go. Because no, David, I've talked already too much, so I'm not going to.
Well, and we
say
can
that,
also agree that we can anything you want to send us, we will send out to our whole team later. So you're
yeah.
also.
Yeah, okay. So there's a governmental organization called the National Council on Disability that literally February 15th of 2022 came out with something that they called their health equity framework for people with disabilities. It was released February 15th. I was actually honored to be on it was attended by 500 plus people, a kind of presentation of it a week ago, last Thursday, I think, where we presented it. It made 4 points about what needs to happen that were the top line points. And the first one is designated people with disabilities as a special medically underserved population, or an SMUP, under the Public Health Service Act. That has not happened yet. We've been trying, but it still hasn't happened. Second, requiring comprehensive disability clinical care curricula in all U.S. medical, nursing, and other healthcare professional schools, and requiring disability competency education and training of medical, nursing, and other healthcare professionals. Third is requiring the use of accessible medical diagnostic equipment, like I've already talked to you about. And fourth, and this is someplace where AHRQ can really take a leading role, is improving data collection concerning healthcare for people with disabilities across the lifespan. The other thing that I think that you should be aware of is that Elsevier, that big publishing enterprise, I want to say 10 or 15 years ago, but time has just telescoped and collapsed for me, so I'm not sure how long it was ago, but they initiated a journal called Disability and Health Journal. And it publishes a lot of health services research, and it has really taken off like a rocket ship. And so it's a place where those of us who are having trouble getting high impact medical journals to have any interest in us, the Disability and Health Journal has really become a good place to go to. And then finally, Health Affairs, Wonderful Health Affairs, in October of 2022, is having a special issue specifically on disability. And I was privileged to be one of the 2 advisors to that special issue on disability. And so I know that they got 171 high quality abstracts that were submitted for that issue. They could only select about 25. And what that is telling us is how much pent-up demand there is, that there's a lot of really high quality, excellent research that's now going on out there about disability, but we're just not seeing it in the high impact journals. So we need to start, to the extent that you're able to, from your pulpit, your bully pulpit, try to convince the high impact journals to recognize that this is an important area, that would be something that could be done.
All great. Many, many great ideas. Thank you. And just so you know that at AHRQ, our definition of priority populations, which is in our statute, we amended it this year to include as a category people with disabilities. So we're with you, we're trying. Yeah. At this moment, as questions, Jamie is going to come back and staff start sharing your experiences and your stories, but I'd also love our new director, Bob Valdez, was able to join us on this call. And Bob, if you would like to ask the first question and say hello to Lisa, I would love that. Look at that, yes.
I'm sorry, Lisa, it's taken me a long time to get these mechanical things working. I was listening to you on an iPad while I had IT people playing with this particular machine. Uh, and you know, you've always been a hero of mine since you started your research. And whenever I think about health equity, I think of you first. And because there are very few voices who've raised the issues of people with disabilities and the difficulties that they have in our healthcare systems, not only the healthcare systems, but all of our systems. And so, you know, I like to remind people that, you know, we often talk about structural racism, but there's actually a structural bias against people with disabilities in many of our systems.
It's every structure, you know?
It's literal.
Every structure, you know, that's the thing about disability. Building needs to be structurally so I can get into it. Yeah. Well, congratulations on your appointment. It's just really wonderful to have you there.
Thank you, Lisa. You hit on a topic that I hadn't mentioned to David before, but I really would like to create a council of journal editors for the agency to interact with, because it really is how they set their publication agenda that affects how we in fact get our messages and our findings of AHRQ out into their readership. And I'm glad you reinforced an idea that I had that I figured everybody was going to figure as kooky, but I have lots of those anyway. I do have a question though, and that is, you mentioned the 4 recommendations. Which do you think would have the greatest impact? Because I would like to see if we could help push those first.
Well, you mean the 4 recommendations from the National Council on Disability?
Yes, recognize people, push curriculum in health services or health care delivery schools, require accessible diagnostic equipment, and increase the quality of our data collection around people with disabilities.
I think that it's like comparing apples and oranges, because they're just such different recommendations, and they go to the strengths of different organizations. I think that that I'd like to take a slight detour about that, and I know that over the years that AHRQ has done a lot of work on electronic health records. And I think that, you know, one of the things is that the Office of the National Coordinator has not been willing until maybe recently to include disability as a recognized field in electronic health records. And so I think that, you know, looking at, because one of the things during the COVID pandemic is that we know that it was a massacre for people with disabilities because of the nursing home deaths and the deaths in congregate living facilities. You know, and one of the things that was so hard for those of us in the disability community was to hear people say, oh, it's just the nursing home residents that are dying, or it's the, you know, it's the congregate living facility people who are dying. Those are our people. But we didn't have any data to talk about that, you know, and so there's something called the 6 questions that the Office of Minority Health came up with as a result of Section 4302 of the Affordable Care Act, that they were told to come up with questions about race and ethnicity and gender and language and disability. And so, you know, looking at those questions, because everybody says that they're great as far as they go, but they don't, for example, catch conditions like autism. We need to do that. And so I think that, you know, within a place like AHRQ, I talked earlier about reaching out to the healthcare provider community about what the barriers are. And I think that that would be a really good area of research to what are the barriers to implementing the medical diagnostic equipment that's accessible. But I also think these barriers to having electronic health record information, to getting accommodation information into the electronic health records. So when I show up at the doctor, they know what I'm going to need when I get there. That I think would have a really direct impact. And, that would require you to come up with a way to categorize disability in the electronic health records. And we don't have that yet.
Thank you, Lisa. I know the staff and others have other burning questions, so I'm going to let them go on. David, take it away.
And I'll turn it to Jamie. Thank you so much, Bob. And thank you, Lisa and Jamie.
Yeah, thanks for kicking us off. We have a couple of questions in the chat. So the first one we have is, it's interesting that 82% think quality of life is lower and the speaker thinks this is disrespectful. My impression is that respondents may have been offering empathy, or docs might have been responding to what is the scientific literature. Does lower quality of life mean your life is meaningless? Not, she doesn't think so. So any comment?
Let me just say that if you were told by somebody who doesn't know you that your quality of life is worse, I think you would probably feel that's pretty disrespectful. And the disability community went ballistic over this because it's based on erroneous assumptions that have been around since, Leviticus, the Old Testament of the Bible, said that people with a limb too long or a hunchback or a dwarf should not be allowed to approach the altar during religious observances because of their disability. So we have to think about the eugenics movement, about the fact that people with disability were forcibly sterilized because they didn't want babies to be born of people with disability. And so this doesn't, and doctors were complicit in the eugenics movement because they were the ones who did the sterilizations. And so this is the result of a long history that reaches back, as I said, millennia. And, I could understand that maybe there might be empathy if you had had a conversation with your patient and that patient said, look, let me tell you about the pain that I'm having. Let me tell you about what my daily life is like. And let me tell you why, from my point of view, my quality of life is worse. But I don't want somebody making an assumption about me based on the fact that I look like somebody who they perceive might have a worse quality of life. I don't want them making that assumption.
Super interesting perspective and helpful as we think about patient-centered work here. Another question from a colleague. Having a daughter with disabilities, I've come to realize so much resistance to seeing people with disabilities as a whole person has to do with fear about becoming disabled ourselves, which is an inevitable part of life, childhood, old age, etc. Any thoughts on that and ideas for how to address this fundamental commonality in a way that is aligned with universal design?
Yeah, I mean, I think that's a very powerful story that you're thinking about your daughter having a way to think about her future life and what her future life might be like, and the fact that her future life might be really, really good. I recently actually had a colleague reach out to me and say, look, I have a child with intellectual disability, and I can't get from Children's Hospital a sense of what his life is going to be like. He's 10 years old now, but I can't get a sense of what his life is going to be like when he turns 20. And so I suggested a number of advocacy organizations that she could go to. And there are amazing advocacy organizations out there now, like the AHRQ, that really can introduce you to people who've lived full lives despite having a particular type of disability. And so I think that there's a very tiny literature out there that suggests that once physicians get to know people with disability, start to hang out with them, get to kind of just interact with them in a casual way, that they realize that we're just like anybody else. that, you know, having your daughter or yourself kind of exposed to people with disabilities at different age groups, you know, would begin to make you feel like, yeah, she's going to have a full life. It may be different than somebody else's life, but she's going to have a full life, and she's going to have a life that she's going to have. And so I think that and it really is just being open to possibilities, being open to living differently, but living well.
Yeah, thank you so much. And I'd like to add or build on that and talk about, we train medical professionals, physicians in particular, and that death is the enemy and that disease is the enemy. And that could, in some people, create a response when they see a disabled body as that's a failure. And I don't want to be associated with failure. And so helping the healing professions go back to that root and not be afraid of death and talking about death, not being afraid of disability and talking about disability. There's a lot in that second component of the 4 recommendations about education of our healthcare professionals, doctors as one part of it, but it does cross that the fear of our own mortality and or being emotionally connected with somebody who might have pain causes us to do odd things, I think, sometimes in
Well,
care.
remember that I told you, David, that I didn't talk about my wheelchair for 12 years because I'd been told by the medical school, by my medical training, that they can't cure me, and so don't talk about it. And yet that was just perpetuating stigmatization. And it was also causing fear. My colleagues were really terrified when I started using the scooter in 1988 because they thought that my MS had gotten worse. And no, it was just that I'd finally gotten smart. I didn't want to keep falling all the time, you know, and the scooter was great. I could tuck a suitcase under my legs. I had this cute little basket. I could put my purse in, you know, I could go around, and it has 2 speeds, turtle and rabbit. And if I go rabbit, I go much faster than you guys do, you know, so absolutely. Yes, I experienced it myself. And so let me just say that the strength with which I'm speaking now is part of 45 years with MS. I have had to learn things in my own life. And so you're absolutely right. But I think that physicians need to be introspective. It's like I was talking to my former research assistant yesterday, because she just finished she's now a 2nd-year Harvard medical student, and she just finished her psychiatry clerkship, her 2nd-year psychiatry clerkship. And, you know, I was talking to her about how because she was saying, I don't know if I could become a psychiatrist because I think it would just be too emotionally upsetting. And I said, you know, that when you train to be a psychiatrist, you go through your own analysis. So you kind of understand your own ways of thinking, because you have to understand how your own projections are going to affect your ability to care competently for patients. And so what you were just saying is that physicians need to really understand how their own attitudes could really compromise their ability to care effectively for their patients. Because trust me, people have antennae. People like me have antennae. If somebody's being disrespectful, I will immediately kind of notice that.
Yeah. Some of the commenters have been pointing out that this discussion about people with disability actually echoes what we heard from talking about ethnic and racial minorities in this country, and in the respect question, that's an example of it. And then somebody else just pointed out that so for Jamie, we had one of our earliest sessions this year was on people with intellectual and developmental disabilities, which, as you started, is one of the categories, not the only in disability. As we said, there are many, but folks who want to think about how healthcare specifically for that one group of people with disabilities we have more that they can learn there. Jamie, I'm sorry, time is flying by. Are there other questions?
Yeah, there's a bunch, but I'm trying to
Prioritize, yeah.
Yeah, exactly. So I'm going to ask this one. In your research throughout the years, did you come across any trends of people with disabilities being deemed as hypochondriac with regards to their struggles by healthcare providers and or employers, schools, etc.? If so, what ideas do you have to combat resistance due to misjudgment or lack of understanding?
I've probably interviewed more than 300 people with disability, either individually or in focus groups, and I cannot remember that having been a trend of what I've heard. I certainly have heard, and this is a complicated topic and we only have a minute left. And so I don't want to get too far into the weeds, but as you know, doctors have to certify, have to fill out like applications for workers' compensation or applications for Social Security disability. And sometimes this can put doctors and patients at odds with each other because the doctor might think, you can keep on working. I don't see that you're so disabled. I don't want to fill out your paperwork for you. And so I have heard of instances like that, both from the side of the patient as well as the side of doctors. And I remember one doctor who said, I just make a policy that I will not fill out paperwork for workers' compensation. I just won't do it.
Oh,
Just Lisa says that. Oh, what do we do about that? Okay, systems. We got to think systems. Yes, Jamie, more. We do have a few minutes.
well, no, I was going to see if there's anything else you wanted to add, but sorry, I'm trying to find the last question, but
Please.
Okay, we'd like to hear more about how to support paid home caregivers and how to improve the quality of home-based care.
Oh, thank you. Thank you. This is where my heart is. And in fact, I dedicated the book, Making Their Days Happen, to my best friend, whose name is Michael, who cannot move any part of his body below his neck because of primary progressive MS, and his longest serving personal care assistant, whose name is Nolita, who is a woman who, as long as I've known her, which now is, 12 years or so, has always worked 2 or 3 jobs. She's a Haitian immigrant. She's exhausted constantly. I think that that there are a lot of kind of steps that need to be taken for both consumers with disability as well as the workforce that I talk about in Making Their Days Happen, but it starts with wages. It starts with wages, because the average wage, and I looked this up recently in the Bureau of Labor Statistics, hourly wage for a home-based personal care assistant is $12.04 an hour. And the average annual salary for a person in this profession is about $27,000 a year. And so clearly with that kind of low wage work, and it's hard work, it's emotionally demanding work, it's physically demanding work. And I want to make the point that it is not unskilled work. There's a sense, because of the gender associations, that it's primarily, persons of color, women of color, who do this work primarily, that it's work where the human body is touched and cleaned in ways that have been associated with stigma and disapprobation. And so there just is a sense that it's unskilled, that everybody knows how to take a shower, everybody knows how to feed themselves, but no. My friend Michael's personal care assistants have identified acute health problems that if they hadn't been noticed immediately and taken care of, he could have been in really, really deep trouble. And so there's a kind of ability, an emotional intelligence that somebody has to have in this profession to be able to do it well. Because at the end of the day, I actually feel that my friend Michael, who gets about 17 hours of personal care assistance per day, that his PCAs are a lot more important to his longevity than his neurologist is.
Great thought to end on, and to ask people or encourage people who are interested to go read the book. I had a chance to read some of the early chapters, and the combination of storytelling and policy making is a brilliant, what you do so well. So thank you for
It's
for
stories.
this.
Yeah.
At this point, I'm sad, I have to say goodbye. I hope we will continue to have you in our orbit. We will all continue to learn from you. Thank you so much for taking this time with us today. Thank you to the AHRQ staff who were able to join today. I hope this gave you lots to think about as we continue to think about how AHRQ can have the greatest impact as a workplace on the health services research community itself. One of the things, Lisa, I'm sorry, I'm going to violate my own rule here that you and I talked about earlier. Where at AHRQ are we thinking about, if a person with disabilities needs additional supports to be a researcher, are we making our funding available in ways that can be used to make them a successful member of their research team or a leader of the research team either? And fascinating, important question that we're going to have to come back to. And then in our biggest way, how do we help the healthcare system improve the quality, safety, equity, and value of care for all people? So thank you for helping us on the journey. At this point,
Well, thank you for having me.
Okay, be well, everybody.
Thank you.
Thank you.